Edwards syndrome, also known as trisomy 18, is a rare genetic disorder caused by the presence of an extra copy of chromosome 18. This extra genetic material disrupts normal development, leading to severe intellectual and physical disabilities. The condition is often associated with a high rate of miscarriage, stillbirth, or early infant death. Causes. Edwards syndrome is caused by a genetic error during the formation of reproductive cells, eggs or sperm. Normally, humans have 46 chromosomes, organized into 23 pairs, with one set of 23 coming from each parent. In Edwards syndrome, the person has 3 copies of chromosome 18 instead of the usual 2, hence the term trisomy 18. There are different forms of the condition. Full trisomy 18, every cell in the body has an extra chromosome 18. This is the most common and severe form. Mosaic trisomy 18, only some of the body's cells have the extra chromosome, leading to a milder form of the condition. Partial trisomy 18, only part of chromosome 18 is present in triplicate, which can also lead to varying severity of symptoms. Risk factors. The risk of Edwards syndrome increases with maternal age. Women over the age of 35 have a higher likelihood of having a child with this condition, although it can occur at any age. It is not generally inherited but occurs randomly during cell division. Symptoms. Babies with Edwards syndrome often have significant physical and developmental issues. Common symptoms include low birth weight. Babies are often small and underweight for their gestational age. Severe developmental delays. Intellectual and developmental disabilities are profound. Physical features. Small head, microcephaly, low set ears, small jaw and mouth, clenched fists with overlapping fingers, rocker bottom feet, rounded soles, prominent occiput, back of the head, organ abnormalities, heart defects. Congenital heart problems, such as ventricular septal defects, holes in the heart, are common. Kidney abnormalities, malformed or underdeveloped kidneys. Digestive system issues, problems like esophageal atresia where the esophagus does not connect to the stomach are possible. Feeding difficulties. Many babies with Edwards syndrome have trouble feeding and may require a feeding tube. Breathing problems. Respiratory issues are common, which can lead to serious complications. Diagnosis. Edwards syndrome can be diagnosed before birth, prenatally, or after birth based on physical symptoms and genetic testing. Prenatal diagnosis. Ultrasound may detect physical abnormalities such as heart defects, abnormal facial features, or poor growth. Screening tests. Blood tests like the combined first trimester screen or the quadruple screen can indicate an increased risk of trisomy 18. Non-invasive prenatal testing. NIPT, a blood test that analyzes fetal DNA circulating in the mother's blood to check for trisomies. Confirmatory testing. Chorionic villus sampling (CVS), a test done around 10 to 13 weeks of pregnancy that involves taking the sample of the placenta. Amniocentesis, performed around 15 to 20 weeks. This involves analyzing the sample of amniotic fluid to confirm the presence of an extra chromosome 18. Postnatal diagnosis. If Edwards syndrome is suspected after birth, genetic testing through a blood sample can confirm the diagnosis by identifying the extra chromosome 18 in the baby's cells. Prognosis. Unfortunately, the prognosis for babies with Edwards syndrome is very poor. Many pregnancies affected by trisomy 18 result in miscarriage or stillbirth. Of those babies born alive, 50% die within the first week of life. 90 to 95% do not survive past their first year. Those who do survive often have severe physical and intellectual disabilities, and most will require comprehensive medical care for their entire lives. In rare cases, children with less severe forms of the condition such as mosaic trisomy 18 may survive into childhood or adolescence, but they typically experience profound developmental delays and health problems. Treatment and management. There is no cure for Edwards syndrome, and treatment focuses on managing symptoms and providing supportive care. Decisions about treatment depend on the severity of the child's condition and the family's preferences. Medical management. Heart surgery. Some babies with heart defects may undergo surgery to improve heart function. Feeding support. Babies with feeding difficulties may require a feeding tube. Respiratory support. Ventilators or oxygen therapy may be used for breathing difficulties. Palliative care. Given the poor prognosis, many families opt for palliative care, focusing on comfort, pain relief, and quality of life rather than aggressive treatments. Support services. Physical therapy, to help with movement and muscle strength. Occupational therapy, to help with daily living skills as much as possible. Special education, for children who survive longer, specialized educational support is needed. Emotional support. Parents and families dealing with Edwards syndrome often experience significant emotional stress due to the poor prognosis. Emotional and psychological support is crucial, and families may benefit from counseling, psychological or grief counseling to cope with the challenges and grief associated with this condition. Support groups. Many families find comfort in connecting with others who have gone through similar experiences. Conclusion. Edwards syndrome trisomy 18 is a rare, severe genetic disorder that significantly impacts a child's development and quality of life. Most affected pregnancies result in miscarriage or stillbirth, and babies born with the condition often have a very limited lifespan. Early diagnosis through prenatal testing can help families make informed decisions about care. For those who survive, supportive and palliative care focuses on improving comfort and managing symptoms